Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world. From border to border, coast to coast, and to all the ships at sea, I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning into the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare delivery and technology. I'm really pleased. My guest today is Steven Buslovich. Dr. Buslovich is the CEO and co-founder of Patient Pattern. He's board-certified in Internal Medicine and Geriatrics, in addition to being a certified medical director in long-term care. Steven, welcome to the Tate Chronicles.
Jim, thank you for having me. It's a pleasure being here today.
You know, this is a topic that's really fascinating to me because it's, since the days of Hippocrates, it's all been based on really delivering healthcare to patients. And with technology and other aspects that keep evolving, the way that healthcare is delivered, we have to keep up with it. But first, I'm curious, how did you get into healthcare generally and geriatrics specifically?
Well, that's a bit of a longer story. I grew up in a household with grandparents who were geriatricians and sort of always had an interest in medicine. I unfortunately had a tragic event in my life where I lost my mother and her brother, my uncle, within a 3-day time span at the age of 15. And so took in my grandparents from my mother's side into my life much closer than a typical teenager would. And, essentially grew up really appreciating the nuances and differences of, their values compared to those of adults, and really appreciated that. And I've always had a respect for those that kind of made it to older age, realizing they've probably done something right in their life and deserve good care. Aside from that personal experience, it's a field that's relatively new. It's less than 100 years old. As a specialty, it's an area of great growth and interest, and things are still very obscure for us as a science. So there's really a great deal of information we have yet to learn and understand about the aging process, how to improve one's level of function and quality at that stage of life.
The whole aspects of geriatric care, which is certainly a growing field because people live longer now. It's been a while since I've been directly in a clinical environment, but if the longer people live, then their decline or chronic diseases certainly accumulate, and so often they, when folks age, that I guess that end of life process or decline of life process is extended. And so, as you say, it's kind of a relatively new, I guess, demographic for care, but it's a growing one. And I know that's kind of what you do at Patient Pattern. What does Patient Pattern do, and who are your customers?
So Patient Pattern is a unified health platform that's designed to help organizations that take risk on these high needs populations, typically geriatric populations that are either living in institutional settings or community settings, and what we call aging in place. We now have a dynamic in the market whereby either insurance plans, health systems, or provider groups, like practice groups, are taking risk on these populations, and they need better tools to be able to identify that risk, focus on what's really relevant for that individual patient, or what sometimes referred to as a member of a health plan. And ultimately, right now, those tools are lacking. They're kind of historically designed for either billing purposes or documentation purposes, or really focus on a much healthier population. And so patient pattern was created for me as a medical director to help me do my job managing nursing home residents and helping to improve quality, and has sort of evolved to helping the broader population.
You mentioned aging in place. That's certainly what everybody wants to do. I certainly want to do that. For folks to age in place, there has to be some type of data or visits or from a healthcare provider or something to track how people are doing. If somebody's in a nursing home, there's people there kind of around the clock. But how is aging in place? How do we track those folks? They're trying to age in place, maybe with a chronic disease.
Yeah, I think that's obviously a growing need. The perspective that I share is a little bit different, perhaps coming from a geriatric perspective. In that I focus less on a disease per se and more on the individual's impact of having a chronic disease or multiple chronic conditions. So for example, if you have 3 chronic conditions in an individual patient, they may still be highly functional and independent. And you could have another patient with the same diagnoses, but they can get out of bed and are fully dependent, right? And so the conditions themselves typically don't tell the full story. It's really identifying what we call deficits in terms of functional, cognitive, or psychosocial domains of that individual, and how those chronic conditions impact that individual across those domains is really the most important thing to look for. I kind of always remember my grandfather's saying to me, it was like, if you wake up over the age of 50 and nothing hurts one day, you're probably dead. And so what we look for is like what's wrong, as a deficit, and really focus on either reversing it if possible or stabilizing it to maintain that level of function and avoid further decline and institutionalization, which is really what aging in place is all about, is trying to not end up in a quote unquote nursing home, but really try to maintain your independence.
And just to get in a little more detail, so patient pattern, correct me if I'm wrong here, but is a software platform that's used during a clinical encounter?
Correct. So the software is used by clinicians that are typically directly interacting with an individual patient. So they're everybody from physicians, advanced practice providers such as nurse practitioners, physician assistants, care managers, pharmacists as well. So ultimately, the entire interdisciplinary team can interact with patient pattern to understand what's happening with that individual, how they're trending over time, and then do what is sort of what we call required work, which is documentation of that interaction, identifying conditions and coding them properly, supporting that work with a plan, an intervention, and a care plan to either mitigate or stabilize those individual issues.
When you use the phrase planned intervention, and so is there some type of predictive analysis that utilizes that data to say, based on what we've known in the past about a group or about this individual, something needs to change in terms of their care plan to head off a problem? Is that what we're talking about?
Yeah, we've incorporated predictive models around a clinical and mathematical model of what is known as frailty. Frailty is an internationally well-recognized, well-adopted model. It's the most predictive model for those with chronic conditions and those of older age typically, but not limited to. It works for younger populations as well. And many countries have adopted a frailty-based approach to managing populations because it's the best predictive model we have to understand, who's at risk for future decline, kind of understand what's around the corner. And the more frail an individual is mathematically, the more likely when they experience an insult or stressor, irrespective of even a minor stressor versus a major stressor like a hospitalization or a surgery, they will have a much greater setback. And think of it as sort of like your fuel tank. If you don't have enough fuel to get over the hill, you're probably not going to. And so the idea is that being able to measure that allows both the clinical team and the patient, the family, to sort of align expectations of what's to come. And so, particularly in individuals who have many deficits and typically chronic illnesses, they may be chronologically young, but physiologically very old. So, sometimes you can have 50-year-olds that are, physiologically equivalent to a 90-year-old. And you can have 70-year-olds that are equivalent to a 115-year-old individual patient. But when you look at them, it's very hard to sort of gauge that. So you really need to assess their degree of frailty. And so the platform helps the clinicians by gathering data to make those calculations and trend it over time. So you can kind of see if the patient's frailty scores and their sort of overall risk for bad outcomes is improving, or it's declining, and really identify whether the interventions and the care plans are working to help stabilize that individual patient. And sort of using math as the basis allows us to make better decisions than just our eyeballs, for example.
Well, in earlier decisions, we all know that you're quoting, I think your grandfather, I'll quote all the grandfathers and grandmothers who said, a stitch in time saves nine. What type of data are we talking about? Is it data like if somebody is diabetic, their hemoglobin A1C values or blood pressure values? What types of data go into this frailty index?
So what's really unique about the frailty model is its age, gender, diagnosis, and lab agnostic. So it really looks at an individual's functional domains, psychosocial domains, and cognitive domains. So for example, if you think of everything that can go wrong with an individual in the course of their life, think about things like, visual impairment, hearing impairment, depression, dementia, balance impairment, incontinence, ability to digest food, ability to eat, ability to transfer out of bed or take a bath, ambulation. You're going to come up with about 50 to 60 different variables that can go wrong with an individual. And frailty looks at how many of those deficits in all those different areas have you accumulated over the total number of deficits possible. And that kind of creates your frailty index and score. And what's great about that is it doesn't really matter what your hemoglobin A1C is.
Oh, yeah.
It's really the impact of that, of everything going on inside one system. So more of a systemic impact on the individual. And that's what makes it very impartial to somebody's living situation, their economic situation, their gender, their race. So it really becomes kind of a leveler of equality when you can look at an individual from a mathematical approach, and really have a much better assessment of where they're likely to go next.
This is fascinating to me. I worked for years in a large pulmonary practice, and we had all kind of sophisticated pulmonary function tests and all kind of ways to measure this or that. but the actual best test was what they call the 6-minute walk test. How far could somebody walk in 6 minutes?
Mm-hmm.
That told us, and that's kind of what you're talking about here, the actual functional status. Yeah. Well, this frailty index is is this standardized? I mean, is everybody using the same data inputs for this, or is it a nebulous concept, frailty index?
Yeah, it's funny you ask. In other countries, like particularly Canada, UK, all over Europe, Australia, Asia, it is standardized, based on their country sort of data sets. In the US, we're far from sort of in agreement across the board. There are many frailty tools and models out there. Some are limited to the ability to do an evaluation only prospectively, meaning at the bedside.
Mm-hmm.
Others, the ones we tend to use and have a model are tools that we can also do retrospectively from existing data, which really gives us more of a historical perspective of how you got here, and that when you can automate that, you can save a lot of time. So, for example, as a geriatrician, it would take me 2 hours to do a frailty assessment on an individual patient from scratch. With our software approach, we can automate that almost entirely,
Mm-hmm.
and frankly, save a lot of time, or take that assessment into a 5 to 10 minute assessment from a 2 hour process. And so that kind of efficiency you can only really garner from a software approach.
The whole concept of in the provider patient reimbursement triangle, I guess there's some other points of the there, but I would imagine that early on the frailty index was, the market for that was somewhat in the provider sphere, but as more and more like Medicare and other ACOs become at risk for, as far as payment models, those are the ones that are really interested in tracking somebody's frailty index.
Correct. And I think that the market dynamics that are evolving right now are quite interesting. What we're seeing is, number one, Medicare, Medicaid are financially defunct. And so they're looking at ways to offload some of that financial risk downstream to downstream providers. So you're seeing new innovative models coming out of CMS that are focused on, creating new organizations out of existing ones that would take on risk for a member population. And I think that kind of trend is going to increase. Those organizations that are now taking full global risk, typically that means financial risk, have to have better tools to understand what they're assuming. And frankly, right now, everything is not designed for that purpose. Everything's kind of designed for a conveyor belt kind of fee for service model. You get paid for a service, whether it drives a better outcome or not. When you start taking on financial risk, you need to think about, well, if we provide this service, does it actually, besides increasing the cost, does it actually improve the outcomes? And does it avoid future costs for the individual, for example? And that really becomes more of a person-centered approach where you start looking at things differently, because the ability to provide services is not infinite. You have limited resources. You have to really think about how you utilize them appropriately, keeping patients' wishes and priorities at the forefront. But ultimately, having that kind of lens when you are managing a population or taking a risk for a cohort is really paramount, because you can potentially make some money as an organization if you can manage that population well, but you could also lose your shirt very quickly if you don't know what you're doing and you're just kind of taking the traditional approach to managing high risk patients.
Yeah. Who are the customers for patient pattern. Who's using your application?
Yeah, we've been growing fairly quickly, particularly in organizations that do take risk, organizations such as special needs plans, both institutional and duals, those with chronic illness. We're seeing a lot of growth in the PACE market, so Program for All-Inclusive Care of the Elderly. That's again, a fully capitated model in a community setting, taking risk for Medicare and Medicaid patients. And then we are seeing tremendous interest and growth across ACOs, particularly as the new ACO REACH model has created over 200 new organizations that are participating in this program starting January 1st of 2023.
And this whole concept of frailty index and using these predictive models, is this something that just maybe in the last few years has started gaining traction? And are we kind of at the, not only for geriatric population, but for really for the all populations involved in healthcare, where it's kind of a hockey stick graph, where as clarification and understanding of these different predictive models come into play, it's going to really spread throughout healthcare.
Yeah, Jim, I think you have to consider, what the historical tools that were available have been, traditionally used. So, for example, what we typically have are claims, and many organizations have developed analytics around claims. Claims are typically only as good as who's submitting them. The reason they're submitting particular diagnoses or claims is directly related to how they're getting reimbursed for whatever service they're providing. They're not necessarily comprehensive. And by the time they hit, let's say Medicare, for example, they could be 6 months to a year old by the time anybody has the chance to work with that kind of data. And so, frankly, when you're looking at a very large population with minimal chronic conditions and frailty, it's a decent way to risk stratify a population. When you start managing high needs patients with potentially shorter life expectancies, by the time you get those claims, their condition has changed so much that they're not representative of what's happening at the bedside. And so clinicians really need more timely, accurate tools, and frailty is a really great one, not the only one, but a really great one that is evidence-based. It's trusted by clinicians, whereas claims are not, for all the reasons I mentioned. And it gives you a more real-time assessment of the individual and kind of what's around the corner versus a claims-based approach, which is kind of like driving forward, looking into the rearview mirror. And so, tools like that are going to need to continuously evolve. That's not to say we don't have limitations and challenges of getting timely clinical data. That's a different conversation, but that's kind of where the market needs to evolve, is providing more bedside tools at the point of care rather than just focusing on back office analytics that never become actionable.
Sure. We're almost totally out of time, but before we say goodbye to our listeners, how can they find out more information about patient pattern and what you're doing and what your services are?
Sure. You feel free to visit us at patientpattern.com. We do have a fair amount of frailty literature and resources available for those that are interested in learning more about frailty. We also offer a national frailty certification and training program through a partner. So that is also available if somebody wants to take an online course. And actually, it's designed for interdisciplinary team members. So, definitely consider us if you are looking to either participate in a risk-bearing model or are starting one yourselves. We would be a great partner potentially for you.
Well, to our audience, thanks for joining me on this episode of the Tate Chronicles. I offer a special salute to my guest today, Dr. Steven Buslovich. Thanks for coming aboard today. and introducing us to the Frailty Index.
Thank you, Jim. Thanks for having me.
You can find more information on this show's program page at healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.